Sir, we are live now.
Good evening to all. Welcome to ExRxIndia's and Sri Samraj Health Services Private Limited's For the Students, by the Students web series. We are moving towards a world record event, and this topic is the 100th episode. That's a special in the students webinar series. And I thank all my friends who supported this so far and our associates, especially Pickle Studio Chennai, Sairam Academy Chennai, uh, and Physioactive from Gurugram, Dusat Creations from West Bengal. And I thank all the resource persons who helped us to reach this 100th episode, and all the students, practitioners, principals, vice principals, professors, lecturers, clinicians, all who participated. That's why we got the success to reach the 100th episode. And as a mark of 100th episode, today we are having a guest from Pune. He is from Tamil Nadu. He is my senior. I am happy that he is present here today. An alumni of Sri Gokulam College of Physiotherapy, Salem. Dr. Vijay Kumar, MSPT, FDSR, London. Department of Kinesiology and Movement Sciences, Professor and Head, Dr. D.Y. Patil College of Physiotherapy, Pune. I request Dr. Vijay Kumar to utter a few words to encourage the students and participants during this 100th episode. Please, sir.
Yeah, thank you, Dr. Chandramohan. First of all, my heartfelt congratulations to Team ExRx with the lead by Chandramohan and the most important supporters of the ExRx team for this 100th webinar. Duna ma'am, the one who's there from day one, right from the beginning till now, supporting the entire technical aspects, and Rupesh, a physical therapist, of course, a technician, and more than that, a backbone of ESRF for Chandra Mohan, who's been supporting from the day one till now for the entire webinars. And of course, other team members whom I know, whom I do not know. But to be very frank in saying that conducting 100 webinar series one by one without even missing a single session or a single day, when everything is going to be in a lockdown situation like this, is definitely not a simple activity, because it requires meticulous planning. It requires a lot of contacting people, finding the topics, ensuring that it's not being repeated, the contents are being found to be good enough, and the delivery and the delivery is found to be good enough, and the individual who is going to deliver your content has to be of quality. Meeting the people, getting their consent, framing a timing, scheduling a timings, getting it technically right for everything, keeping yourself ready and equipped with all the technicalities, going live with all the technical supports, and then keeping all your 100 participants always full. Because I have seen a lot of webinars that's open and people come in and go out, but when I witnessed the ExRx, I always found that the entire bunch of registrations are always full, and you don't have a new entry for any vacancies. And good, they have gone live. And this indicates that the demand from the webinar conducted by or organized by ExRxIndia is definitely of quality. That is the reason people are actually flocking behind it. And the best thing again I want to say is that he is all the way hailing from Tamil Nadu. The participants are all over India. The support and technical individuals are all over India, from West Bengal to Chennai. We have got supporting people, and the resource persons are not only from Chennai, not only from India, they are even international. So getting people internationally for the webinars, getting them planned on the platform, scheduling them, getting them connected is definitely a meticulous job, and I appreciate and congratulate the team ExRx with Chandra Mohan, Dunamam, Rupesh, and other colleagues that you're doing a wonderful job. One, for enlightening the physical therapy professionals by giving new information and knowledge. Number two, giving information to people that we can do a different way of learning apart from your regular teaching in the colleges. Number three, igniting the fire of learning as a continuous process through all the professionals and students. And definitely number four, that no professional is found to be below your quality. So all the professionals who have been here had been of quality, which indicates we physical therapists are definitely of quality, not only in case of clinical management, it also in case of academics, and not only academics, in also technical concepts. So I wish all the best for Chandramohan to continue this particular program. Henceforth, also for how much ever he could do, maybe I wish him that he can do 200, maybe 500 if permits, reach higher world records with this fantastic team, always smiling, enthusiastic, and pro supportive being with you. So I wish you all the best. Congrats for the entire journey of 100 episodes. And the best thing you're doing now is for the students and by the students. You have a different view of encouraging people, because usually people do not permit or support or encourage students to go ahead, and you're given a good opportunity for students also to join in. That's to be well appreciated. So fantastically done by you, Chandramohan. Fantastically done by your team members. I wish all the best, all for success, and I wish and pray and hope and bless that you will reach 200 to 500 episodes of series and create a world record. Create a world record, not only just because it has to be created, create a world record with quality participants, with quality presentations and quality content for a fantastic professional information and sharing of knowledge. All the best. Keep going.
Thank you, sir. Thank you so much for wonderful, encouraging words. Actually, I don't have any words to say now. I also feel happy about it. And not only that, your presence is also making me happy. Your contribution towards our ExRx India's webinar session is also very appreciable, sir. It reached many people, and there were a lot of appreciations for you also. And in forthcoming webinars also, you have given appointments for 3 topics. I never thought of it actually. Your contribution also has a major role in our success actually. I say it as our success now. And
I am there 200% with ESRX.
Thank you, sir. Thank you so much, sir. Thank you so much. Success goes for all the resource persons, sir. Not only for 1 or 2, or we don't want to climb it. Our part is 50%. The remaining 50% goes to the all graduated professionals, RPs and student RPs also. They are not less than any RPs actually. And mostly while we are ExRx India, we physiotherapists are far better than abroad physiotherapists also. We have the resources. That's why we mainly concentrate on the resource person inside India. So that is one among the reasons. Still we are getting international resource persons. Those who took a webinar or those who know the webinar conducted by ExRx, they come forward, they ask. So we are giving opportunities for that also. We are happy about it. And don't take much time. We will go on to the 100th topic, sir. Might be the resource person will be waiting. And the topic is, thank you, sir, thank you. Anatomical and physiological difference between pediatric and adult lung. Resource person is Teffeny Meshack from one among the popular and globally acclaimed college, St. John's Medical College from Bangalore. So, Teffeny, are you there?
Yes, sir.
Please start the session.
Okay, sir.
All the best. Do well.
Thank you. Thank you, sir. Can you see my screen, sir?
Yes, we can see your screen. Please continue.
Okay, so good evening to one and all, teachers, students, and my dear friends, St. John's Medical College, Bangalore. So I would firstly like to thank that ExRS seminar organizers for giving me the opportunity to participate in the seminar. And I'll be talking about the anatomical and physiological difference between the adult and the pediatric lung. So we all know the adult normal lung, the anatomy and the functional physiology of the lung. But today we will know how different the pediatric lung is that of the adult lung. So introduction. Lungs are the major organ of respiratory system. The primary function of the respiratory system is for gas exchange. At the molecular level, the gas exchange occurs in the alveoli. So alveoli is the tiny sacs which are basic functional component of the lung. The alveoli epithelial tissue is extremely thin and permeable, allowing for gas exchange inside the lungs and the capillaries of the bloodstream. So the air moves accordingly to the pressure differences like high pressure and the low pressure. Anatomy of adult and infant lung. So adult lung, these are the pair of respiratory organs situated in the thoracic cavity. So the texture of the lung is spongy and the color is brown or gray. And the shape of the lung is in conical shape. As you all can see in this picture, the upper respiratory tract, which comprises of the nose, nasal cavity, pharynx, larynx, and trachea. The lower respiratory tract, which comprises of the bronchus, bronchioles, lungs, and the alveoli. Moving on to pediatrics. So pediatric age groups, first is the extremely premature, which is less than 28 weeks of gestation, then premature, which is less than 37 weeks, then neonates, which are the term, 28 days after birth. Infant is typically applied to the young children who are under 1 year of age, and child 1 to 12 years, adolescents from 13 to 16 years. So coming on to the anatomy of infant lung. So the lung develops from an outpouching of GI tract, and the maturation is not complete until the age of 8 years. And the surfactant, it starts producing at 24 days of gestation, and by 24 weeks, the surfactant with the lipoprotein begins to appear. These are the alveoli sacs, as you can see in the picture. Next is the physiology of infant lung. So we look into the parameters of the infant lung as well as the adult lung. So the neonate has limited respiratory reserve volume, which comprises of inspiratory reserve volume, expiratory reserve volume, and residual volume. And the tidal volume is about 6 to 8 ml per kg. Then total lung capacity, which comprises of 50 to 90 ml per kg. And the FRC is relatively low as compared to the adult. As compared to adult, neonates and infants cannot hold their breath as long as an adult, and which can lead to onset of hypoxia and decrease in saturation. These are the parameters. As you can see, the respiratory rate, which is more than the adult, tidal volume almost similar, dead space, again, it's slightly increased, alveolar ventilation is more than the adult, functional residual capacity is almost same or it's decreased, and the oxygen consumption is much higher than the adult. Now we'll come into the main part of the session, that is the difference which is in between the pediatric and adult. So first I will talk about the upper respiratory tract difference. As I say, please look into the picture. First is the tongue. So tongue is larger in pediatrics and normal in adults. In this picture, you all can see it's more broader and larger. The epiglottis shape is more floppier and omega shaped, and in adult, it is firmer and flatter. And the pharynx, as you can see, the pharynx is much smaller than the adult. Then coming on to trachea. Trachea is smaller and shorter in pediatric. In adult, it is wider and longer. Then larynx. Larynx is more situated in anterior and superior part, and the shape of the larynx is funnel shaped. But in adult, it is column and straight up and down. The narrowest part of the trachea goes on in pediatric is at the subglottic region, which is the cricoid cartilage, where the cricoid cartilage is present. And in adults, it is at the level of vocal cords. And lung volume in pediatric is about 250 ml at birth, and in adult, it is about 6000 ml. So I will be talking about the upper respiratory tract difference in detail. First one is the tongue. Tongue is relatively large for mouth, and there is absence of teeth in pediatrics. And because of this, what happens is the airway gets obstructed easier. But in adult, it's not like that. It's normal. And the nasal passage is more narrower in infant. And because of this, the airway resistance is increased up to 50% in infants as compared to adults. Pharynx, as I said, it's smaller in infants and longer in adults. Epiglottis, it is long, stiff, and omega shaped, and it flops posteriorly. But here in adults, it is broader. Thyroid and thyroid separation is very close. I will show you in the next picture. And the narrowest point, as I said, in infants, it's at the cricoid cartilage, and in adults, it is at the vocal cords. So in this picture, you all can see this is the larynx, which has thyroid cartilage and the cricoid cartilage. So in adult, as you can see, this trachea is of cylindrical shape, but in infant, it's funnel shaped. This is the narrowest point in which it happens in infants. As you can see in the right side of the picture, it is shown more clearly at the cricoid cartilage. There is like a narrowing of the shape. Coming on to larynx, the position of larynx is much more higher in infants as compared to adult, and at the level of C4 and C5 in infant. In adult, it's a bit lower, C5 to C6. Shape of the larynx is funnel shaped, and in adult, it is cylindrical shape, as I showed in the picture earlier. So, high larynx enables the newborn to breathe and swallow simultaneously up to approx 3 to 4 month of age. And the high larynx position, it is relatively low resistance of the nasal air passage, which contributes that the infant will be more onto obligate nose breather. And also the larynx cartilage is more soft and collapsible. Moving on, the vocal cords in infants is concave in either neonates and its present slant anteriorly. In adults, it is horizontal. As you can see in this picture, the epiglottis is more shorter, but in adults, more broader. Now I'll be talking about the lower respiratory tract difference. So first one is alveolar. So alveolar multiplication in the infant is rapid during the first year of life, and it continues approximately 8 years of life. And the capacity of infants to increase alveoli is protective. And postnatal alveolar growth, the formation of conducting ducts and airways, is completed by 16 weeks of gestation. In the first one shows the terminal bronchiole with the alveoli at 16 weeks. At 19 weeks, the respiratory bronchiole is formed with the alveoli. Then at 28 weeks, transitional duct and saccule is present. At birth, the terminal saccule is developed, and at 7 years of age, the alveolar duct and the alveolar sac is formed. So the airway diameter and structural support are reduced in infants and children, and this causes more obstruction and collapse in the infants. So because of this, alveolar, there is small in number and in size, which causes more collapse, that is atelectasis of lungs. Moving on, the full-term infant has approximately 1/20th the alveolar surface area of adult. So in this picture, the left side shows preterm lungs, wherein the alveolar surface area is much less when compared to a term baby. The alveolar surface area is more. Second difference is channels for collateral ventilation. There are 3 channels of collateral ventilation: pores of Kohn, which is present in between alveoli. Then there is a channel of Martin, which is interbronchiolar. Then channel of Lambert, which is bronchiolar alveolar. So pores of Kohn, it develops at the age of 1 to 2 years, and channels of Lambert and Martin starts from 6 years. So in infant lung, the upper right lobe and the right middle lobe. So these two lobes, they have fewer collateral channels as compared to adults. So this can cause more incidence in atelectasis. So third one is rib cage configuration. So rib cage in newborn is much circular and in the horizontal plane, and in adults it is more a triangular shape. The diaphragm angle of insertion is horizontal, and in infants the rib cage is more cartilaginous, but in adults it is more rigid, and there is less efficiency of ventilation, and there is more distortion of chest wall shape. So why there is more distortion of chest wall shape is because the ribs are more cartilaginous. By 2 years old, the bucket handle action of the rib has developed. So at the age of 2, the bucket handle motion will start and lungs become equally compliant. By 3 years, when more time is spent upright, the ribs are more oblique than horizontal. So which means at 3 years, from horizontal rib, it translates into oblique rib. And over 10 years of age, they are considered adult, anatomically and physiologically. Hello.
Let's continue. It's okay.
Okay. So the fourth thing that we're going to see is chest wall shape. So as compared to adults, you can see in this picture, fetus at 7 months, newborn, then at 3 months, then 3.5 years. So all of this, the AP diameter as well as the transverse diameter is almost equal, but in adult, it's more elliptical. And when you see anteriorly, the ribs will be in triangular shape, but in infants, it will be more circular. So this is the physiological difference. First is oxygen consumption. First, we will look into the parameters, that is tidal volume and the total lung capacity as compared to adult is more. Then there is increased respiratory rate, which causes increased work of breathing. Then chest wall compliance. So compliance in neonates, it's more relative to adult, and because of this, they are prone to collapse during inspiration. And therefore, there is decreased tidal volume for same respiratory effort, which again causes increased work of breathing. Then tissue compliance. It is decreased in neonates, and in full-term infants, it is increased only at the first week of life. And because of low compliance, which means there is greater inflation pressure, which is created to maintain the lung volumes. And so the infants must work more harder to ventilate their lungs, which also can cause respiratory muscle fatigue. Fourth one is surfactant. Surfactant is the function where it reduces the surface tension of the lung. So in infants, it is not produced until 35 weeks of gestation. It is deficient and alveoli are maintained at low volumes. Because of this, there is decreased functional residual capacity, that is FRC, as commonly occurs in several neonatal diseases. Then work of breathing, as I said, overall work of breathing increases. Respiratory pattern. So neonates, they normally exhibit irregular respiratory pattern as compared to adults, and they use more of diaphragmatic breathing. Neonates, they compensate respiratory difficulties, like instance, if they're having any respiratory distress, rather than increasing the depth of the ventilation, they increase the rate. So hence, it causes increased respiratory rate. Breathing. Apnea, the cessation of breathing, it occurs for long enough periods of time to produce bradycardia. So commonly it's seen in infants who are distressed, and it's by intraventricular cerebral hemorrhage or sepsis. So when we position in prone position, the premature infants, It results from greater ventilation and improved oxygen. It's not only for neonates or infants, even for adults. Prone position, it increases the ventilation and oxygenation. Sleep pattern, when we compare neonate into adult, the newborn, it sleeps up to 20 hours per day. And mainly they sleep, 80% of sleep is REM, that is rapid eye movement. And there is greatly increased work of breathing during REM sleep. So this is secondary to decreased postural muscle, that is the intercostal muscle tone, which causes the upper rib cage to move inward as the diaphragm contracts. And because of this, there is further increase in work of breathing of 30% reduction in FRC during REM sleep. Next is the diaphragm. The diaphragm of neonate has reduced percentage of approximately 25% as compared with adult who have 50% of type 1 red slow twitch muscle fibers. So these oxidative fibers, they help in breathing as well as the strength of the diaphragm. But when we compare it to neonate, they have less than adults, that is 25% when compared to 50% of adults. And this can cause respiratory muscle fatigue in neonates. Last is the cilia and mucus. So cilia is immature. Cilia is a movement which causes the movement of secretions, and there are also more mucus glands. So finally what happens is when there is retention of secretion in the lungs, there is more mucus gland production, secretion is more, then there is immature cilia, therefore there is increased retention of secretions. So that's the end of my presentation, and thank you all for listening. Thank you.
Thank you, Tiffany. It was a nice presentation with a mild, soothing voice. It was very beautiful.
Thank you.
Chandramohan sir, you there?
Thank you, ma'am.
You can stop screen sharing now.
Yes, ma'am.
Rupesh sir, you there?
Actually, I'm here, madam. My screen didn't work actually. Touch screen didn't work. I'm coming.
Yeah.
Yes.
Please.
Thank you, Tiffany.
Thank you, sir.
Good.
Sir, are you there?
Good.
Network problem, it seems.
I guess so, ma'am. Let us wait for some time, ma'am.
Yes, yes. Special episode, special practice. Since he has got disconnected.
I think he is reconnecting now.
Yes, maybe. Sir, enjoyed this session, sir? DK sir, I'm asking you.
Yeah, of course. Definitely, like I should appreciate two things from you.
Yes,
One thing
sir.
was your confidence in your presentation.
Okay, sir.
Being young, I should appreciate that you have been very confident in presenting your contents. So that's my first hats off for you. And
Thank you,
second
sir.
thing was you have been very clear and crisp in what you wanted to say.
Thank you, sir.
That's to be appreciated because like at this young age, people normally have an issue of beating around things and try to present with unclarified contents. So you had a lot of clarified contents in your presentations in what you actually wanted to do, and I should appreciate this. And what else you wanted for a webinar to be presented? Confidence, clarity, and what you are clearly presenting what you want to present, and the contents and the way you are presented with the slides that is being made. The slides were clear, they were short, crispy, and it was not too much of content where it will be clearly going. So a mature presentation, that's what I could find it from you. Keep doing it well. Hats off. Congrats to your presentations, and I wish you all success throughout henceforth in the future also.
Thank you so much, sir. Thank you, sir.
Thank you, sir. So many good words from you, sir. Nice to hear. Thank you.
Chandramohan sir is here, ma'am.
Has he joined? Seems he might be on a call or something like that. He's not in the meeting.
Okay.
So can we conclude or wait?
1 second, ma'am.
You call once him.
Yeah. I guess I'll conclude it, ma'am.
Yeah, I think so. Because we are having upcoming session.
Yeah.
Because sir, if you have time, you can join us,
Sir
please.
has joined.
Yeah, CM sir is here.
I'm there, but I'm only switching off my video because, like, I don't want to.
Yeah, okay, sir.
That's it.
Just be with
Hello.
us.
Yeah, sure, of course.
Yes,
I'm
sir.
hearing you. That's why I said I was happy with Teffany's presentation. That's why I was very clear in saying that young people with such quality presentation
My mobile.
and right selection from you guys.
CM sir, your voice is not clear to us actually.
Okay, no problem, madam. Please continue.
Am I clear now?
Yeah, your voice is
Yes, sir,
fine.
your voice is clear. I could not hear Chandramohan sir actually.
He's a busy guy. Probably he has got multiple phones and he's busy with it.
Thank you, Teffeny. Thank you, Vijay Masar,
Yes, sir.
taking
With you
charge of
always.
conclusion. And you were saying something about the students, actually. I thought that they might need some guidance. But really, none of the students, resource person asked for guidance. They are doing their best on their own. And they are mesmerizing us with their skill and knowledge.
And all presentation are so good, so beautiful. It's
Yes.
nice to attend all.
Shall we conclude?
Yes, sir.
Yeah, I think, sir. We are having a
Thank
session
you,
upcoming.
Vijay.
Thank you, everyone.
For a wonderful session. Thank you, my ExRx team and friends, Dr. Rupesh, Professor Duna, Dr. Vairav, and many are there actually today in the students webinar. The strength is more actually now, beyond 30. I'm happy. Yes, Riya, thank you for your presentation and attendance also. Thank you all. We will join for the 101st webinar. The next topic that is also presented by a student. Please stay with us. And we are having a guest also, especially for Teffeny. Please join with us.